Good evening, everyone. Welcome back to my IVF Answers and the European Fertility Society. We are back with one more topic, one more educational webinar for you. And I hope you have lots of questions because we have our fertility expert with us. As you can see, Dr. Laura García is with us, and she's the medical director of Clínica Tambre. And if you have been following my IVF Answers, you know that she's been here with us before, and I'm sure it's going to be an interesting and very informative session. And as always, we will start with the presentation, but afterwards there will be time for your questions. I hope you had them prepared. If not, remember, you can type those in the chat during the presentation or afterwards as well. Hi, Dr. Garcia. Welcome back. Great to see you for sure. And I know it's still quite hot in Madrid, but I'm glad that you are with us and are ready to educate, to answer some questions. How have you been? Lovely to have you.
Hi, Caroline. Everything it's okay. So starting the new course after summer, still very warm, but the weather is changing. So kind of irregular, but very happy to have you this evening.
Definitely. We are glad that you are back. It's been a while, I think. It was definitely too long, so I'm glad that you are back. And we will discuss today the pros and cons of endometrial receptivity tests, ERA test, ER map, and of course, Dr. Garcia will be happy to walk you through all the steps, when to perform it, how it works, and afterwards, as I've mentioned, there will be time for questions. So if you have any, go ahead. Remember to type those. And now I think we can go ahead with our presentation. Right? Ready to begin with the
Of course,
presentation?
thank you.
Brilliant. Thank you so much then. Let's go.
Okay, so this presentation today will involve about what are the pros and cons of endometrial receptivity tests. What will we cover? Today we talk about the endometrium. We will talk more specifically about what are the endometrial receptivity tests. The third point will be the test that we offer in our clinic in detail, which is in Tambre, the endometrial solution, the dinner size test. Number 4, if we have any disadvantage when doing receptivity tests and our conclusions. What is the endometrium? Is the innermost layer of the uterus. It's the internal part of the uterus where embryo implantation and the fetus development takes place. If we think about the natural menstruation every month, the menstruation, it's that part, is the endometrium when we don't have a pregnancy, when we don't have an implantation, that is kind of going out, and then it will start in a new cycle having a new preparation. So due to our own hormones produced by the ovary, the endometrium undergoes significant changes every month. The hormones are the mainly estrogens in the follicular phase that produce in the ovary the lining thicken to prepare for the potential pregnancy. And the second part, the luteal phase, it's mainly by the progesterone, also produced in the ovary by the luteal cyst, that prepares the endometrium, changes the endometrium, makes the endometrium more receptive, so playing this lining and stimulating the glands to grow to being capable the embryo to implant. So why is so important the endometrium? It's because for embryo implantation, the endometrium must be in the best possible condition. It needs to be trilaminar in appearance, the morphology, and needs to be in a thickness ideally from 7 to 12 millimeters. We know that the protagonist in the reproductive treatments is the embryo. We always work very hard, gynecologists, embryologists, patients, in achieving the best embryo. But in order to succeed ongoing pregnancy, we need a competent endometrium. And unfortunately, because of different reasons, it could be we have cycles, they are very good in terms of embryos, but if the endometrium is not perfect, we are not going to be having the objective of implantation and ongoing pregnancy. So we always have by routine the 2D scan, and of course, if necessary, any other images testing such as 3D scan, MRI, even hysteroscopy to study the morphology of the endometrium. But also sometimes it's recommended to undergo endometrial receptivity tests during our treatment, when we will see different occasions if we are not succeeding in different transfers, or if we believe something is not going okay. So each fertility clinic offers different tests. So we all know receptivity tests, it's kind of general, but then you always need to ask your doctor about what tests they offer and why they recommend these tests and not any other. However, all these tests called endometrial for igenomics, endometrial solution for Zina, AirMap have a common goal, which is to test the perfect moment to carry out an embryo transfer in regards to the progesterone. So this is called the window of implantation. What is the endometrium test we offer in Tambre? We offer the endometrial solution. This is the Dana Science test. And we have two subcategories of this endometrial test. One is the S time, which is to do with the window of implantation, the timing for the transfer. And the other one is the S meta, which is going to study the infections, the possible abnormalities in the microbiome in the uterus. Both tests required a biopsy, which is performed by our gynecologist in consultation. So it's not necessary to be under sedation, but of course, it's sometimes painful. So we always recommend to come with ibuprofen before the moment of the biopsy, 30 minutes in advance, and to come with a bladder full as when you're going to do the transfer. And we perform both time and meta in the same biopsy. The only thing is that when we perform both tests, we need kind of a good sample. So if we don't obtain enough sample in one biopsy, we should repeat to have enough RNA to be able in the lab to have both results. The report of the results will arrive in around 15 days. So whenever we do a biopsy, we should wait for the results before starting the new endometrium preparation for the next transfer. So what is time in particular, this test? So this is the test that provides information on the patient's window of implantation. So the window of implantation, again, is the time when an embryo needs to be implanted. This period of receptivity is short, and it is the result of the effect of the estrogen and progesterone in the endometrium. The results may be obtaining pre-receptive, receptive, or post-receptive. 25 or even 30% of our patients have problems in our window of implantation. So it's not the general basic protocol of 5 days of progesterone, and could be different, could be before, could be later. So ideally in these patients, if we do this testing and we plan the transfer in regards to the window of implantation, we will have more probabilities to implant the embryos and to have ongoing pregnancy and not have miscarriage. What are the indications to do time tests? When we don't know the reason of this infertility in that couple, and we have done many transfers and also this is not happening, so implantation failure. Let's talk now about META. META detects the presence of any pathogens such as bacteria, virus, fungi in the endometrium. So if necessary, it will explain the need to do any antibiotics or any treatment in particular. Also reveals the proportion of lactobacillus and what kind of percentage of lactobacillus we have. So if necessary, we will improve the microbiome of that patient. These species of lactobacillus will be typified to determine if the composition is adequate for the pregnancy or if by contrast an imbalance is happening and we have less probability to implant and more risk of miscarriage. So if necessary, we will ask the patient to reestablish the endometrial microbiome by using lactobacillus specific kind of lactobacillus oral vaginals to try to make the pregnancy more competent. When are we talking with our patients to carry out META? Again, when we don't know the reason of the infertility, when we have implantation failure, and we, in these both scenarios, ask for time and META together. When we have recurrent miscarriages, so patient is implanting, the embryo is implanting, but we don't have the ongoing pregnancy, we're also recommending to do these tests. And when we have previous history of bigenosis or any other infection in the uterus. Are there any disadvantages of these tests? Of course, we always need to remember that these tests may be inconclusive. So it means that we do the treatment for the time, so estrogens, progesterone, or even natural cycle monitoring the endometrium and then triggering and doing progesterone. So all 2 weeks of ultrasounds and taking medication and then coming for the biopsy, and perhaps we don't have a good result, which is something we need to repeat in a new cycle. And also it could be that the window of implantation we are not identifying correctly, so they need to do different biopsies because they are not capable to understand which is the best moment to transfer. So in one of my patients in these 11 years I have treated, she did 3 or even 4 biopsies, and that was a big challenge to have the receptivity. So our conclusions today, since the endometrium plays a key role in fertility treatments, endometrial receptivity tests can also do the same, which is really improve our chances, have a high result of ongoing pregnancy. Failure to recommend it to a patient in time can cause her to spend much more money on her treatments, doing more IVF, more egg donations. So be sure to choose a clinic you trust and they explain all possible strategies, including this test and any other strategies that could improve your chances to implant. And be very well informed about these tests, as there are also occasions when they are performed without being, of course, necessary. And of course, they are consuming time and money. And keep in mind that they are usually valid for 1 year. So if you continue with a project and you are not getting your pregnancy, it could eventually be needed to repeat the biopsy. And thank you very much for your attention today. I will be completely happy to answer all your questions.
Excellent. Thank you so much, Dr. Garcia, for introduction to this topic and explaining all those details. Some of the questions you kind of already answered during your presentation, but there are some other ones, and I believe we can still have a look at them. Let's see the first question. Let me show you. What is the role of P4 testing in frozen embryo transfer?
So the role of progesterone testing, it's because we really need to make sure before starting to open the window that the progesterone is less than 1, and before the transfer 24 hours monitoring that the level of progesterone is high enough. So we have these two testing as a routine before opening the window, just to make sure that before we start the external progesterone supplement, being vaginal or subcutaneous, the endometrium is not working with progesterone. So if we really need to have 5 days of progesterone, we need to check before these 5 days that the progesterone is lower than 1, and the day before the transfer or 2 days before the transfer to confirm that the level is high enough and we don't need to put more progesterone.
Thank you for your question. And of course, if you have any follow-ups, you know what to do. And let's have a look. Now we will have a longer question with some details. So I have had 7 fed transfers, implantation failure. I'm preparing for the next cycle, and receptivity test will be performed beginning of October. I would like to have your opinion on doing IVF immediately next cycle, how the protocol should be scheduled, since I had the down-regulated protocol for ERA and would like to do IVF with own eggs.
So, of course, if you have had different transfers, it's of course necessary to have this receptivity test, ERA, and also EMA analysis. And if you're working with iGenomics, because it's not worth to continue doing exactly the same transferring. It could be that there is a problem with your embryos if you haven't had PGTA, or it could be that you have thrombophilia and coagulation disorders and you need to use Clexane or baby aspirin. But of course, it's also necessary to check your window of implantation and your environment in the endometrium, that you don't have infections in a previous month. It's always necessary to remember we cannot test this in the same moment of the transfer. So it's minimum the month before. If all is good, we can go ahead the next transfer. But if we need to use probiotics, if we need to use antibiotics, we should need to postpone. And always remember that if we really have an infection, we need to repeat. Or if we have a post-receptive test, the laboratory will require a new sample to make sure which is the moment for the transfer.
All right, thank you so much for that as well and your explanation. There are some follow-ups, so I will go straight to that one because this is the question from our previous patient. So is it possible to add injectable progesterone to vaginal route, and what is the best to use?
That's a very good question, of course. Thank you so much. So we have the protocol as general speaking, because patients, they prefer not to inject, normally speaking, they prefer the vaginal, but of course there are exceptions. And because the subcutaneous, sometimes it's painful and more expensive, so we normally recommend vaginal Pezaris 400 milligrams every 12 hours and monitor blood tests the day before the transfer. And if it's not minimum 10 nanograms milliliter, to include progesterone injectable. But of course, there are some patients that they absorb very, very difficulty, and they prefer to go ahead with subcutaneous progesterone, or they don't like the vaginal absorption and they prefer injections.
Okay, Again, thank you so much. Very helpful indeed. Okay, and let's take a look at Maria's question. So, what can cause the change of the endometrium receptivity?
So we don't know the reason of the possible reasons. One of them, it could be, for instance, adenomyosis. Adenomyosis is one of the possible problems also in implantation failure. It's glands of the endometrium in the walls of the uterus, in the myometrium. We know that this could be one of the possible causes why receptivity is not like generally for other patients 5 days.
Okay, thank you. There was another question from Maria. Let me go to this. So, are there any recommendations for nutrition supplements to increase endometrium receptivity?
So unfortunately for the receptivity, there is nothing and we can do. So we need to have a good appearance of the endometrium, we need to have a good thickness, but it's more to do with the function of the expression of when the endometrium is ready to implant. And we don't know why sometimes patients they opened the best moment for the transfer 6 or even 7 days, whereas others it's less than 5 and it's 4, and it's not clear the reason why some patients they don't have this general protocol 5 days.
Okay, thank you. Once again, Maria, I hope that answers your question. And more of those are coming up. So let me take a look. How much do the tests cost? Can you provide us with some
So
idea?
I'm not sure exactly, but it's kind of around 1,000 euros if we do both the S time and S method to
Mm-hmm.
maximize all the results in terms of receptivity and microbiome. And if you only do one of the tests, it could be probably be around 800 euros.
Okay, thank you. And if you can explain here, what is the EBM for ERA?
What's ABM?
I'm not sure as well. So please let us know what you mean by that. And we will go back to this question then, okay?
Thank you.
Evidence based. Sure things.
Okay, so evidence, it's not 100% sure with error. There is a big controversy. There are some authors that are not relying error tests. There are other authors in the literature that, of course, they are relying 100%. In my opinion, it's another possible strategy when it's a big challenge in a patient with very good embryos to implant. And this is something just to discuss with patient in regards when and at what moment we should have this biopsy. So again, this is nothing that we can always say for everybody, but of course we know in some percentage of our treatments it could be helping.
Okay. Again, brilliant. Thank you so much. And you've answered this actually during your presentation. So, how long can I rely on one result of the endometrium test? When should I repeat it?
So our laboratory, and generally speaking, all laboratories, is the 1 year validity. And always very important to remember, Caroline, that it's always when you're doing exactly the same protocol. So if you change protocol and you change kind of a strategy instead of natural cycle doing hormone substitute therapy or the contrary, it should not be exactly the same. So very important to remember 1 year and always doing the same preparation.
Of course. Brilliant. Thanks a lot again. More questions are coming in. Next one is here. Are the probiotics that you orally take for vaginal microbiome the same as you take for digestion?
It's not
Sorry.
exactly the same. So that's, one of our, extra advantages doing meta, that we make sure exactly what kind of probiotics, if oral, vaginal, what percentage, it's the best, for that patient in particular. Whereas others, biopsies testing, such as EMMA, they just say, generally speaking, to use probiotics.
Okay. Thank you. And Lynn would like to ask, is there a point having this if I had early miscarriage at 10 days and at 8 weeks after transfer?
So when I understand it was 10 weeks and 8 days.
Uh,
So when we implant, sorry, I'll turn on my lights.
sure, that's good.
So when we have miscarriages, we should use exactly the same preparation because the receptivity was okay. And only in the event of biochemical miscarriages, or when we cannot see the sac, then perhaps we should do the time. But generally speaking, miscarriages would have a much more benefit doing meta than time tests.
Okay, brilliant. Thanks a lot for yet another explanation. And let me have a look. Of course, more questions are here. And there's a thanks from Lynn for you, obviously. And let's see. The question I have is the next one is here. If I have had 3 failed transfers with medicated cycle where I transfer on day 5 of progesterone, can I just do a transfers without doing ERA, but just add another 12 hours of progesterone?
Sorry, if I have had 3 failed transfers with medicated cycle where I transfer on day 5, can I just do a transfer? I mean, of course, but this is not what we recommend. When we have 3 failed transfers of very good morphology, so blastocyst 3 expansion, blastocyst letters A or B, we understand that there is a possible problem. We don't say it's the endometrium receptivity. Again, it could be the genetics in the embryo. So, of course, very important to understand the quality of the embryos, to understand the age of the eggs, and understand many other things, but always recommendation of doing a biopsy. And I wouldn't transfer with 5 days and a half, but of course, it's an option because the majority of patients they have the maximum receptivity 5 days and a half.
Okay. Thank you so much indeed. Let me have a look. Okay. So, can IV intralipids help the endometrium preparation?
Intralipids shouldn't be the treatment to improve endometrium. It could be more the PRP, it could be more baby aspirin, vitamin E, and any other supplements. Whereas intralipids, it's more to modify the immune response in people having problems with the immune system and could be with natural killers attacking the embryo. But of course, when we have problems in the endometrium thickness, we always have solutions such as PRP and any other strategies.
All right. Again, thank you so much. Next question is here. So, with a history of BV, doctor recommended antibiotics prior to next transfer. Would this be recommended before having ES tests as well as after?
With a history of BB, Caroline,
BV, here, we need some help with that
we need to
shortcut.
confirm. Sorry, it's late
Sure,
in the
of
evening.
course.
We need to.
Not a problem at all. We will go back to this question if you can just type the what you mean exactly by BV.
Sure.
Yeah. Thank you so much. We will continue and we will go back. So the next question is, what is the ideal measurement of the progesterone on transfer day?
So the ideal measurement of the progesterone on the transfer dates, I mean, it's not exactly the day of the transfer, but of course we can do it. The thing is that if we don't have a good result, then we cannot modify. So it should be realized, carried out that minimum the day before. So with the supplementation, increase the progesterone. There are different studies. Some of them they cut with 8 nanograms milliliter, and if we don't achieve the 8, then we supplement more. We have a more restricted level, and we say 10 nanograms milliliter. And if we don't have minimum 10, we improve progesterone. We increase progesterone.
Okay, brilliant. Thanks a lot. And we will go back to the previous question. So it was BV was bacterial sorry. I will show you that will be just much easier. Here it is. And the question is, let me just go back. So here it is.
Okay, with a history of bacterial vaginosis, doctor recommended antibiotics prior to next transfer. Would this be recommended before having test as well as after? So, of course, the ideal is if we have vaginosis to do the antibiotics that the doctor recommends. But if we are doing the S test, then my recommendation is to wait for the result and do not overtreat if it's not necessary.
Thank you again for that question and helping us out with the shortcut. Now we will go to the next question. So I did all other tests you mentioned. ERA is the last one remaining. I'm just worried about hormonal therapy before ERA. Can differelin influence egg production in the following cycle?
So, ERA is last one remaining. I'm just worried about hormonal therapy. I mean, hormonal therapy, it's not 100% necessary because if you're doing natural cycle for your endometrium preparation for embryo transfer, you can always do natural cycle. So only necessary hormone therapy if we will do hormone therapy in the moment of the transfer. And of course, the ferulin influence egg production, not really. Okay, so this is like only to control the ovulation in a period of time. So that's it.
Okay, thank you. Thank you indeed. And let's have a look now. Would like to ask one more question. So I recently did the test and it was found I was pre-receptive. I did not have any of the strands lactobacillus bacteria in my uterus. I was advised to use vaginal probiotics. How long do I need to use this before to be prepared for the transfer?
Super interesting question. Thank you so much. So they say it's minimum 3 months to have like a good improvement, but of course we know 3 months it's really a lot for our patients. So we recommend minimum 2 to 4 weeks of treatment of probiotics and always continue until the transfer. So if we have the results, but then we're planning transfer in 2 months, we always recommend doing probiotics for these 2 months until the moment of the transfer. And if we are failing and we need to do a new transfer, we will always recommend to do more probiotics in another cycle because if not, it could reduce the chances of implantation.
Okay, again, brilliant. Thank you a lot. And let me see, is there a place for intralipids and LMWH in repeated failures?
Of course, absolutely. So this is one option, nothing to do with endometrium receptivity, but of course, if our endometrium has a good morphology, our cavity has a good shape with 3D scan, our receptivity, time, meta, everything is working okay, our embryos are good morphology, are genetically tested, we need to work with this kind of other medication that can improve our implantation. And of course, always it is possible to do, like, generally speaking, without the need, without the evidence, or we can just do the test and use intralipids, claxane, or heparin only if necessary. So there are both strategies always much recommended to test.
Right. Again, thank you so much indeed for that. One more question. So is it necessary to have EMA and ALICE tests as well as ES tests? What's the difference?
It's exactly, very similar. If we do ERA, would be exactly the same for time. So different laboratories, different companies, different enterprises, but always studying the same. So it's more to do with the difference in the genetics profiles of what a test or another, but should be very similar. And EMA and ALICE are the same as the meta biopsy. So it's more to test with the infections, which is exactly ALICE, and EMA, the microbiome.
Okay,
So of
thank
course
you.
not necessary to do both. Okay, very expensive one only, so both even more.
Definitely. Thank you so much for that. There are some questions left, so we will be finishing. However, if you have any more questions, go ahead, type those in. And let's have a look what elevated progesterone level on the beginning of the cycle can indicate.
So it indicates if it has been like a previous ovulation, like a changing in the ovaries, like starting producing endogenous progesterone that sometimes we produce, of course, at every cycle. So it's kind of more, infrequent to have elevation of the progesterone when there is menopause, and it's more possible when a patient has like regular periods, and even we are doing like artificial treatments, our ovaries can start doing progesterone in the ovaries.
Okay, thank you. And let me have a look. Might be our final question. So if you have any, you know what to do. And the question is, so apart from the blood group, are there immunological tests to know the compatibility of the donor with the recipient? I tried IVF twice with egg donation, but it didn't work.
Yes, of course. So if we're working with egg donors treatments and it's not working, other strategies apart from the endometrium testing, it could be the immunological test. We have our doctor Padir in our unit for the immune, problems, and we will test depending on the care, the natural killers, many other possible problems that in young women's perhaps they have never had any previous problems and only it's the reproductive failure. We will make sure if we need specific selection of the donors, if we need specific treatments in advance or during the transfer to kind of change the immune response.
Okay. Thank you once again, Nadia, for your question. I hope that helped. And in the meantime, we did receive one more question, so let's take a look. What tests would be recommended for women with adenomyosis and fate transfers with top embryos?
So when we have adenomyosis and failed transfers, what we recommend is, of course, studying receptivity because adenomyosis could be one of the reasons why this is changing, and also doing specific protocol of blockage of the hormones, of inducing menopause, artificial menopause, to try to reduce adenomyosis. And of course, if necessary, doing surgery if it's a focal adenomyosis that can be improved with surgery.
Okay, again, thank you. Let's have a look. One more question. So, if I have had fate transfers with will 3 months down regulation with Lupron help, or is it necessary to do ERA?
So, with 3 months down regulation with Lupron, it could help if we are having adenomyosis, but this is nothing to do with ERA. So, I suggest doing both strategies. So, doing ERA receptivity tests and then also before transfer, going for the down regulation.
Okay, again, thank you. And I'm just waiting. Someone is typing, so let's have a look. So if you have any more questions or follow-ups, this is your time. If not, we will be finishing for today, but I already think it's a very interesting session. Lots of questions, and let's see, there's another one. So how do you know if there are immune factors? What are the tests?
How do you know if there are immune factors? So, if immune factors are always tested when we have, failures or we have repeated miscarriages, when we don't know exactly what's going on, we don't have any big problems. And by contrast, we are not having the ongoing pregnancy. And this is always mainly studied in blood tests, but of course, also sometimes it's studied in biopsy of the uterus with natural killers testing and many others, but mainly in the blood tests.
Okay, thank you. Can adenomyosis prevent implantation?
It could be one of the reasons why we have less implantation rate and more miscarriage rates.
Okay. Again, thank you for the confirmation to this. And I'm just waiting again to see. Probably no, this is a thank you. So let us know if you have any more questions. Of course, you can get in touch with Dr. Laura and her team at Clinica Tambre. And I also want to mention that there will be free private consultation, right? Upcoming on the 20th, 29th and 30th of September with you, Dr. Laura. Is that correct? In where is it exactly, if you can remind me?
London.
It's in London, exactly. So I will put a link, actually, if anyone who is interested, you can use this link, and that's how you can actually register for it. So I can only encourage you to take a look at this, and perhaps you can get a chance to meet with Dr. Garcia face to face. And thank you so much, everyone, for joining us, for your questions. I do believe it was very, very useful and informative. There are things are coming up your way indeed, Dr. Laura. So thanks a lot. Thank you for the information and awareness, encouragement. Thank you so much indeed for all this comment. Yes, is the consultation, I mean, is in person in London, right? It is
Correct.
possible. 29th and 30th of September. You can look at this link that I have just sent to you and register there as well. And okay, one more question regarding the consultation. Can it be online, Dr. Garcia? I'm sure you
Of
can answer
course.
that as well, right?
We're
It can
always
be.
happy. We're always happy to have online consultations.
Definitely. You just need to get in touch with the team at Clinica Tambre. I am sure they will be happy to help you out. So don't hesitate. And of course, as you can see, thank you all for marvelous work, and hope to extend your efforts in the Middle East. Okay. Thank you so much for your comment here as well. You never know. Okay. You never know. And as you can see, more thank yous are coming up. So, Dr. Laura, thank you so much. Lovely to have you back as our fertility expert and guest. So, thank you a lot. And I just want to add one more thing, that we will be back actually this week. We will talk about fostering fertility in the workplace. So, this is a new topic. We haven't done it yet. So, if this is something that you think might be interesting for you, join us. We will be there with Louise Sawitsky. She is actually in Australia, so the time will be different. It will be early morning, but if you can make it, 10:30 a.m. UK time, and we'll be there. But of course, remember, it's all recorded, so you will have a chance to rewatch this if it's too early for you, of course. And once again, thanks a lot. Take care, and hope to see you back here on Thursday. Dr. Laura, till the next time for sure. Take
Thank
care.
you so much.
Bye.
Bye bye.